Hi, everyone. Welcome back. I'm Gabriel Allen Cummings.
And I'm Sonika Garcia, and this is Breaking the Code,
a podcast series by the Havas Medical Anthropology team. We're here to take the BS out of behavioral science by illuminating the why behind the what of behaviors, rituals, and symbols that people take for granted. We hope to arm you, our listeners, with the tools you need to make sense of behavioral science and help you apply it to your work as communication extraordinaires. So hi, everybody. Welcome back. This is episode 45 of Breaking the Code, and it's a pretty exciting one. We have a special guest. This is going to be part one of a two-part episode. We're trying new things here on Breaking the Code, but it's also exciting because we finally got Sonika back. We've been talking about her for a while in her absence and everything, and so you heard her voice in the intro a bit. Sonika, let us hear from you. How are you doing? How's the family? Welcome back.
And thank you so much. It's so nice to be back. I definitely had FOMO when I was listening to all the episodes while I was on leave, but you guys did an amazing job. It feels good to be back. I have a 5-month-old and my 3.5-year-old, so life's a little chaotic, but very excited to be back, and what a great episode to come back to. So yeah, I'm looking forward to it. Gabe, thanks.
What a great episode indeed. We have Eirásmi Lopez Cobo. I'm just going to jump right into the intro. Ada is what Ada lets us call her, is the EVP of Brand Strategy and Consumer Insights for Republica Havas Health. With over 20 years of experience, Ada is a cross-cultural marketing expert and passionate health equity advocate. She has led strategies for pharma and healthcare clients like Pfizer, Sanofi, Pasteur, Regeneron, Amgen, Eisai, Merck, and the American Heart Association, addressing disparities in multicultural communities. Honored as a 2024 MM Women of Distinction, Ada is also the founder of the Wellness for Growth Foundation, a nonprofit empowering underserved women, a co-author of the bestseller Extraordinary Latinas, and a frequent national speaker that combines her expertise with a dedication to creating meaningful impacts in healthcare. Ada, I know we've been talking for a long time about collaborating, working together. We're a few projects in where we are working together in a few different aspects, but welcome to the podcast.
Hey, Gabriel and Sonika, thank you so much for having me here. Super excited, such a fun, and very grateful to both of you for the work that you do and for really raising awareness of such important topics that everybody really needs to learn. So super excited to be here.
And we definitely have an important topic to discuss today, and this is the white paper that your team has been working on, Equity in Action, Mapping the Multicultural Patient Journey for Inclusive Strategies. We'll include the link to that in the show notes. The white paper offers insight into systemic barriers and health-related behaviors for diverse audiences across the patient journey and provides thought starters for healthcare marketers to successfully connect through culturally relevant strategies. And that really coincides with what we're going to be doing on this episode, providing those thought starters and really building in and going into the data. The data will be available, as we said in the show notes, but this is really the double click into a lot of the things that we found interesting across the patient journey. So Ada, let's just start at the very top. What was the goal of this white paper? What was the inspiration for it? And how was the research conducted?
So the goal from the get-go was to be able to raise awareness by doing a deeper understanding of barriers and drivers of multicultural patients across the patient journey and raise awareness of these disparities and how unmet needs can really completely differ from one ethnic group to the other, and how in order to build inclusive strategies, you always have to start with a data-driven, patient-centric approach. So what we did in terms of the research is that we partner with M3MI, which are the syndicated arm for M3 Global Research, and a national survey was conducted. And this is a survey that it has a double base with 40,000 participants. It's an online survey and it's bilingual, so you have the option to answer it in English or in Spanish. And for the specific executive report, we cut down a sample of 23,000 participants where we compare Hispanic, African American, and Asian American patients' behaviors throughout the journey against non-Hispanic and non-Asian whites. And also in order for us to build the sample, we selected participants that had a specific set of conditions, health conditions that are considered comorbidities for most indications or conditions out there in order to make the findings interesting and representative across indications.
Amazing. Thank you so much for going into that. And I think one question that everyone usually has when they're reading through research, and especially research on a similar topic, is really, what are the barriers to treatment that we need to know about, that we need to dive into, that are important for us as healthcare communicators and brand communicators to know about. And so two really came up in the white paper. Can you talk through what those top barriers were?
Yes, absolutely. And as you mentioned, there are multiple barriers all across the patient journey. When you start at the beginning and you start thinking a little bit about disease awareness, you have two top barriers that are key. One is health literacy. Lower health literacy impacts multicultural groups, and particularly Hispanics and African Americans, Asian Americans, especially the more acculturated, tend to have higher health literacy than their Hispanic and African American counterparts. But health literacy is grounded on a plethora of factors, systemic barriers, and also cultural barriers and socioeconomic barriers. And when you think about it, it's the foundation of everything. So if you don't understand the information that is out there regarding a specific condition or a condition that you have, or if you don't know where to find it, or if you don't know how to have informed conversations with your doctor in order to advocate for yourself, then you're starting from the get-go with a disparity that is going to affect your overall health outcomes.
Yeah, so I would love to just stop there because I think health literacy, I mean, it's not so much a buzzword anymore, but I think in the last maybe 5 years, it's sort of 5 years ago, I feel like it started to become more of this buzzword of like health literacy, cultural competency, and all of that. So the way that you're kind of explaining it, the way that I understand health literacy is, as you said, it's to be able to access information, comprehend the information, and then act on the information, whether that's, a discussion or knowing what to do, what are the next steps. And I always find, and okay, well, this is N of one, but I'm curious as to what you think. I think that we focus a lot on the access and the comprehension piece of it, making sure that it's at the appropriate reading level, and are they able to find this information easily, whether it's a website or at their doctor's office. But the acting on and like next steps, I feel like is where it kind of falls off. And maybe you have been exposed to and you understand something that's being told to you about your health condition, but you don't know, like, okay, now what am I supposed to do about it? How do I have an informed conversation? It's not information alone, right? We know that. Where do I go to, make my vaccine appointment? Things like that. Something so simple as that. So I'm curious, in the research, with health literacy being a barrier, did you see one of those three things kind of rise as the more significant barrier, or was it sort of all just together as?
Exactly. It's all of them together as one, as you're saying, they're all intertwined. And this is based on this research and then, additional research that we have been doing all throughout the year, speaking to these audiences and helping brands build meaningful relationships with these audiences and move the needle when it comes to health inequities. At the end of the day, I mean, yes, in order to act upon a specific information and have productive conversations with your doctors, you need to start by thinking like different groups have different barriers that hinder those relationships with the doctor. So if we're thinking about African Americans, we're thinking about the historical mistrust, racism, bias, medical experimentation, all of which play a role that is going to have an impact on how those conversations are going to happen. If you're thinking about Hispanics, for example, and the less acculturated, they're less familiar with the healthcare system. So that's also going to have an impact with their healthcare conversations with their doctors. But then it gets to not only is, helping them overcome that, but empowering them so they feel that on the one hand, they have the self-confidence to speak up and self-advocate. And then on the other hand, preparing the ground so they are receptive to receive the information that they're going to receive from their doctors. And then the last piece of that, and it's part of Gabe, what you were saying, that this is a part one of a two-part conversation, is not only the burden is on the patient, there is so much work that needs to be done on the other side of the coin, which is with HCPs, to address their cultural competence and unconscious and conscious medical bias, so those conversations can happen and so our patients can act upon the information they received.
Right. So a couple of things. So you use the word confidence, and I want to talk about that a little bit because I think,
Mhm.
it's hard. It's hard to build confidence, point blank period, in a lifetime, right? Especially when it comes to health conversations. It's challenging. I mean, just a little anecdote from like my life. I've been in healthcare and I have a public health background, and I find myself to be someone who has, above average health literacy. So I think, and I'm a confident person when it comes to advocating for myself, I think, right? And then when I was actually in a situation where I was having a baby, I was vulnerable. It was the first time I really had like a quote unquote medical issue, or, all that confidence quickly went out the door. And I didn't really know what to say, how to say it, should I say anything? And it was me, and I think it's building the confidence in myself in a different way than I previously thought. But a lot of it, yeah, like it is the healthcare provider too. I mean, you're not just often dealing with your doctor. It's nurses, it's admin staff, it's people that you're not comfortable with. I think we think like I have a great relationship with my doctor. You might, but in a health crisis or any sort of health situation, you're not just talking to your doctor. And I think that's also important, an important consideration at least. So yeah, confidence is a big part of it, but it's a challenge. So
It is a challenge, and you're not alone, Sonika. I have exactly the same examples and similar background and working in healthcare, and then suddenly you
yeah,
go to a doctor and you're in medical distress and you forget medical terms.
yeah.
English is not my first language, and I'm in there and I'm like, how do I say that X, Y, and Z happened to
Mhm.
me
Mhm.
when I'm not feeling well? And then immediately you get dismissed. And what happens is that, again, because of that medical bias, that many times it's unconscious,
Yes.
but it needs to be addressed. Then if you come in and you're not perceived as someone who, let's say, is fully proficient in English or who fully understands what the information that they think they're providing to you, then that bias plays in all the way from diagnosis to treatment. Different
Yeah.
treatments are offered based on the perceived ability of a patient to actually be able to access it or to adhere to it. And many
Mhm.
times that's based on stereotypes, perceptions that are not close to the truth, but are influenced by multiple factors.
Right, right. And you touched on mistrust as well as one of the reasons, one of the barriers. So could you go into that a little bit more, in just like the findings? Was mistrust something that was a significant barrier? Was there a specific, I have my hypotheses, but what were the specific populations that had more mistrust in health? Anything there that we should be mindful of?
Absolutely. So yes, when it comes to mistrust overall, as we know, for the African American patient population, this is a big barrier to be addressed. And it has to be addressed the right way by adding value. It doesn't happen overnight. Your African American patient population needs to perceive and needs to feel that you care about their health by providing them the information, the education resources that they need. And then when they come, that's, you as a pharma brand, you as a healthcare provider. But then when you come or they come to the doctor's office at that point, they also need to feel that they're not being dismissed from, as you were saying, Sonica, the different kind of like members of the healthcare team, because it's the APPs that have the first initial touch point and they play such a role when it comes to start building that trust, and then by your healthcare providers and so on. So again, it's one of those where you can start by providing the information, but if there is no cultural competence, when they get to the doctor, everything falls.
One thing about this idea of mistrust, and I really like the way you articulated it, because it's important to highlight as we have this conversation about multicultural patients, that this is like an umbrella term that encapsulates a lot of different people. So that white paper breaks down Asian American, Hispanic American, African American, and mistrust, when we apply it there, it looks differently to these different groups, right? We talked about how African Americans are going to feel apprehensive because there's a history in the United States of using Black men in particular to be tested on, not believing Black women's pain when they are giving birth. Did you find any distinctions there between, like, Asian American, for example, your Hispanic patient population, as far as mistrust goes?
Correct. And this is based on this paper and the, as I mentioned, additional research that we have done around it. So yes, African Americans, we were saying, as you were mentioning, Gabe, definitely it's because of that history of mistreatment and feeling misunderstood and feeling experimented upon. So that really leads to a lot of self-advocacy. You have African American patients feeling that they have to advocate for themselves, all the way from conducting the research to trusting their networks to being able to speak up at their doctor's appointment. Then when it comes to the Hispanic market, depending on the acculturation level, it's a little bit of a different story. And it's a little bit, yes, there is mistrust, but a lot of it is being driven by not being familiar enough with the healthcare system. And it's very different when you're coming from Latin American countries where your healthcare provider becomes almost a family friend, and your healthcare provider spends a whole hour with you, and it's a little bit more of a holistic approach. And then Hispanics, many times they come to the US and they feel shocked that they're only going to get maybe good 7 minutes with their doctors, and everything else it's being done by the APPs, or so immediately they feel dismissed. And they're like, why is the doctor not paying enough attention to me? It's a different system, and they don't know where to start or look into resources. And then when it comes to Asian Americans, we do see a lot of difference depending on the acculturation level. We do know that for Asian Americans, they do have higher education and higher income level when you compare them with their multicultural counterparts. So usually at that point, for the more acculturated group, the mistrust comes more from like, you need to give me all the information that I need to make my informed decision, because I know about this enough to be able to do my research and then get in there. And then you will either kind of like verify what I have learned, or maybe if you're going to send me in another direction, tell me why, and send me to a place where I can find more information. Where the less acculturated Asian Americans, then it's a story that is a little bit more similar than the less acculturated Hispanics, where you have a little bit more of a holistic approach to healthcare and a very different experience with Eastern versus Western medicine.
That's interesting. I'm just curious well, two things. Did different groups outline what was most important that a doctor should have, or like, is it like a certain quality that would help build that relationship? Because I know, like, I'm just thinking about myself and my parents. My parents are Indian immigrants, and when they look for a doctor, like, their criteria is very different from like who they feel like, oh, this is a good doctor. And then I'm just different, being an American Indian. So was there anything like that came up?
So not in the specific research, but yes, and additional research that we have done were, to your point, Sonika. So being of the same ethnic, cultural background and racial background helps. Unfortunately, there is lack of representation of multicultural groups within the medical community. So it's
Right.
hard, especially when you go to specialty doctors. It's
Mhm.
hard for these patients to find doctors sometimes of their same ethnic background. It's a little bit easier on the Asian American side than on the Hispanic and African American side, but it's hard. And it doesn't mean that a multicultural patient is not going to trust at all a non-Asian, non-Hispanic, white doctor, but it does mean that that doctor needs to have the cultural competence and needs to be aware of his or her own biases in order to be able to truly build the relationship. And the relationship building it takes time. So it's one of those that it's a little bit more of a long-term approach. And what we have heard in many different indications is that multicultural patients go from one doctor to the other until they feel that they're heard and understood. And a key part in that many times, for example, is their holistic approach to healthcare. We hear that over and over again. A multicultural patient will go in and we'll talk a little bit about what they're doing. They're taking a specific RX, but they're also doing X, Y, X, Z holistically, right? Because it's part of culturally how they address health. And then as soon as the doctors dismiss that approach, you shut them off.
Yeah,
and then
totally.
everything else sometimes just doesn't resonate.
Yeah, it's so interesting. And we can move on, but I think another interesting hypothesis that I have that I would love to test in research is like, I think we assume, or I think it's true for some groups, that you want a doctor with a similar background as you have, right? But I wonder if there are certain groups who actually would not prefer that. And that is like, there's I don't know, I have my hypotheses about that, but like, I don't necessarily want a doctor who looks like me or has my background. I have a subconscious bias on what I think a smart doctor is. This was programmed, from childhood and blah, blah, blah. So I look for that. I'm curious, with research to kind of tap into those like biases that people don't even really know that they have when selecting. I think it's easy to be like, yeah, like, I love when I find an Indian doctor because, they get it. And it's like, do you? I don't know. Like, is that really what you're looking for? So I always think that that's interesting. But anyways, let's move on because there's so much to talk about. But thank you. That's fascinating.
It's a founded hypothesis. Biases exist everywhere on the HCP side and also on the patient side. So that can be our next phase of research, Sonika. And we'll do it together.
I would love it. I would love it.
And it's so interesting because we're having these conversations of like cultural competency, and I'm getting excited, and I have like things, and it's like, but I feel like the HCP and the training part of it, that's going to be for our viewers. That's going to be what's going to go into our part 2 in our conversation. Sanika, to your point about like selecting the doctor and patient bias about what kind of doctor they want. I mean, it even comes down to like age, right? Do you want a doctor that's your age, or do you want a doctor that's a little older?
Totally.
I don't know if anybody really wants a doctor who's younger than them, which is definitely interesting in itself.
When he listens to this episode, I feel like whenever he goes to the doctor, it's like a new doctor, he'd be like, I was this super smart young guy, like he loves when he gets like a doctor in his 30s. And I feel like it's funny because I think my mom's like the opposite. But anyway, it's interesting. It totally is.
I think it takes us nicely into like, we talked about mistrust, but the important thing about mistrust is that when we think about it, it's not just somebody saying, I don't trust the health system, I'm going to sit at home and not do anything. These people still have needs, they have priorities, they engage with the health system, whether they want to or not, because they have certain priorities. So Ada, through your research, what parts of personal health did you find multicultural patients emphasizing and prioritizing?
It's interesting because when we're thinking on drivers, right, we were talking a lot about a lot of different barriers. But then when we're thinking on drivers, it's how do you put together communications and information and a plan that could motivate these audiences. So one driver that we found that really over-indexed for multicultural is the importance of physical appearance, of looking good. And then, of course, the connection between looking good and feeling good. So that is one that, and we have seen it in multiple campaigns where, dialing it up for multiculturals helps. And for example, let's say if we're talking about a derm indication and we're thinking about Hispanic women, there's a lot of emphasis being placed on how Hispanic women look, and it really plays a big role as part of their self-identities and the self-esteem. And then the same thing if we're talking about African Americans and skin of color and the emphasis that is being placed on skincare and so on. And I know, Gabriel, that you have a lot of experience on the topic, especially lately. So that is one that is an interesting driver. I don't know, if you want to add anything to that.
I mean, I think that's definitely an interesting driver as far as like it's like seeing is believing. We talk about trust, and I think that the physical appearance part of it, and just one thought that comes to me is what's intuitive, right? What makes sense? And so if I, you said it at the top, Ada, look good, feel good. That it kind of resonates for me for as far as like not totally all in on everything that the health system has to offer, just because of again history, language barriers, mistrust. We talked about it already, but when I see that I'm feeling healthy, then I can internalize that and feel healthy. There's also a mental health aspect of it too, where if I look in the mirror and I like what I see, then I'm going to feel more improved. My health is going to be better. My day is going to be better. I'm going to interpret myself to be more healthy.
Exactly. And then hand in hand with that, it goes, the need for control. So when we're thinking, and this applies more African American and Hispanics, they really lag behind when it comes to preventative health, right? They tend to wait because of all the different reasons that we have mentioned and many more that we're not going to have the time. They wait longer in order to access healthcare. So what is a driver? How can you turn that around if you provide options or information that helps them increase the perception of control over their health? These are groups that tends to live more in the present. They're more present oriented versus Asian Americans that tend to be more future oriented and planning for the future. Hispanic and African Americans are more present oriented. And then of course, there are several pressing needs when you think about the Maslow pyramid that sometimes they need to prioritize over their health, right? So it really helps when you are giving them information about a specific, let's say, prescription, or giving them disease education information that makes them feel like, oh, wow, so I can definitely have an active role on my own health. And that ties back very nicely all the way back to that self-advocacy.
I think I want to call out an important distinction, or I think a lot of times you said they wait longer to access health. A lot of times we hear that and we think, well, they're waiting longer, so they're not caring about their health. They're not actively, researching their health. They're sort of like aloof and out of touch. And it's not that. Just because they're waiting longer to access healthcare does not mean that the journey up until that point is like, I'm oblivious and I'm disengaged. And no, they are engaged. We need to find out in which ways and how to find them earlier in the journey. Not like, what do we do when they're there at the doctor's office? That is almost too late. They've had a journey before getting to that point, and we need to like explore that. I think just as a call out when we apply research, I think that's something that as brand communicators, healthcare communicators, we need to think about, like, this is what the research is telling us, but let's really understand what that means and not jump to certain conclusions, right? So
That's
I love
exactly
that.
right, Sonica. It couldn't be more accurate because there is a perception that they're just sitting in their houses
Yeah,
waiting to just get sick, and then the
right.
burden is on the patient. When, on the contrary, multicultural patients over-index on searching for information
Interesting. Yeah.
online, trying to find what they need. Remember, if you have lower health literacy, then you're just trying to find answers. So that is on the one hand. They also over-index, and this is very important, on going to their social networks, caregivers, family, friends, extended family members, community members, to find information. So as part of your strategies, to your point, all the way from the beginning, you have to weave in those trusted networks of support, because depending on the type of information that they're going to have, that's going to either help the patient throughout their journey and to even get faster to the doctor, or hinder that
Mm-hmm.
process. So caregiving strategies, for example, for multicultural audiences are key from the get-go.
Yeah. Yeah, absolutely. Okay. I think something else that was in the paper that I think is interesting, going back to like what aspects of personal health and are being prioritized. A lot of times we see, I mean, across so many categories, this prioritization of holistic health measures over, prescription, OTC. So can you talk to us a little bit about trends that you saw in, in groups that were more likely to believe that non-prescription medications are safer, and like what's important to know about that? Because I do think that that's specific to certain multicultural groups, but I also think that we're seeing that just become more popular and as a whole, like the trends. Yeah, we'd just love to hear more about that.
Yeah, I mean, overall, when it comes to a holistic approach to healthcare, all throughout the different multicultural groups, they yes over-index. It means different things, but for different groups. But at the end of
Hmm.
the day, there is more of a belief that there is the connection of that mind, body, spirits of the different areas of integral wellness. They all go hand in hand, and depending on your cultural background, then that's going to mean a different thing. Like, there are cultures where specific elements are addressed with herbal remedies, and there are other cultures where faith plays an important role when it comes to, like, for example, African Americans, an important role when it comes to their health. And actually faith-based organizations are key partnerships to be considered when you're putting together community approaches for African American audience, and also for Hispanic audiences. And so yes, it's different. But when it comes to OTC or over the counter, to your question, Sonica, so what we're thinking is that, or what we're seeing is that it's considered safer by the groups that have lower health literacy, by
Okay.
Hispanics and African Americans. Because again, they don't know what they don't know many times. So they are more likely to say, well, if I can get this over the counter, it might be a little bit safer, right, than other options. And that's why the role of communications is key. And we're going to talk a little bit about trust later on, because I think it's a key point. But in order to inform about safety and efficacy. Then
Yeah.
when it comes to Asian Americans are less likely to consider OTC medication safer, also playing into that health literacy. Then when you compare the RS, or the prescribed treatment efficacy perception over the counter across the different groups, you will see that Hispanics are a little bit more likely to think that it will be effective. For African Americans, at face value, they do not consider that they're going to be more effective than over the counter. And then there again is where those messages on efficacy and safety that are targeted, that are in culture, are key.
Yeah. Yeah, that's such a good point. I think understanding the trend of like, okay, maybe a certain group prioritizes or values or is more comfortable with a holistic health approach when compared to like an OTC or an RX. It's really like uncovering what are those feelings that are making them gravitate towards that option. A lot of times, as you're kind of saying, it's fear-based. And for our role, it's important to understand what's driving that fear and not how can we position our branded prescription treatment as that. It's not going to be that, but I think if we understand where the fear comes from, to your point, if it's transparency and communications from a safety standpoint, whatever it may be, if it's the way a doctor communicates about a certain treatment, we at least are doing our part in looking at this from many lenses. So it's not just to say like, oh, they just prefer natural options because that's, what it's not that that's what they want necessarily.
Mhm.
It's just that's what they think is safer, or they can trust it, or whatever it may be. It's important to look into the reasons that someone is going about that. So yeah,
And another
thank you.
thing is like Ada mentioned like this word control, and that's really stuck to me as we're going through this
Yeah.
section. There's like different ways that it manifests, but I see it as people want to have control over their health decisions. And when health literacy isn't there and the trust isn't there in the health system and doctors, then you have to take that into your own hands. And whether it's, pursuing preventative health or reaching out to this OTC medication, one thing I'm seeing throughout the entire thing, and we could loop in the telemedicine aspect of this too, is that the future of healthcare looks like it may be taking place outside of the clinical system more and more. Ada, is there any data that's supporting that?
Yeah, so this is what is very interesting about telemedicine. So there is a perception that multicultural groups cannot be reached through telemedicine because there is a digital divide. And that can be farther from the truth. Usually, when you look at multicultural groups, they over-index, for example, on mobile usage. And mobile is what you use most of the times to do telemedicine appointments. So when you look at preferences across groups, you're going to see for telemedicine, for example, Hispanics and Asian Americans being more likely to prefer it, African Americans being less likely. There are different reasons for that, and they are not all connected to what, the immediate thought is that it's like, oh, they just don't know how to, go into a link, or it's more about, again, that trust in the conversations that they're going to have online, right? And how are they going to build a relationship through telemedicine, and how are they going to get to a point where they can trust recommendations and so on. So those are considerations that need to happen, because if these patients are already feeling that the conversations with their doctors are very brief and almost sterile and not warmth and welcoming, then when it comes to telemedicine, we need to think on how are we going to build relationships online with these patients.
Yeah, it's so true. Okay, I have a lot to say, but I want to really quickly touch on support. You mentioned it before, so I want to just bring it back. As far as like where groups turn to for information, we know that it's not just their doctor, it's not just in the healthcare setting. You mentioned friends and family. I think that totally makes sense because it's a trust thing. So it's, I trust those in my social circle, and the ones that I do trust, I'm going to go to for health information. Is there certain people that they, trust more than others? Is it also online communities and people that they don't even really know? Or is social circle as in like people that they talk to on a daily basis? Like, what does that look like for different multicultural groups?
And that's a wonderful question, Sanika, because yes, it starts from the inside out. So they're doing a lot of research online, and then from there, they're going to their family members, and many times family members for these groups, remember, they're more collectivist. So we're talking about extended family members, not your immediate mom, dad, and the kids. It's extended, large families. And then from there, many times, as we mentioned, it's even friends and neighbors and community organizations, which are key because many times they have been filling in gaps from the healthcare system, faith-based organizations and community organizations where they go and they do daily activities and they build support groups. And the support groups many times are either on-site or online. We have seen through multiple indications how our multicultural patients really go to online support groups to, learn and to connect and to feel heard and to feel that they can also become advocates, because many times their motivation, again, collectivist groups, their motivation to share their story, it's not only for themselves, but also to help those in their community and their family members. But on top of that, there is a key insight that I really want your listeners to know about, which is the trust in pharma, which is counterintuitive because you will think, well, they don't trust the healthcare system, so are they going to trust pharma ads or pharma communications? And what happens is that multicultural groups, based on the research, tend to over-index in trusting pharma, particularly more Hispanics and African Americans than Asian Americans. And why is this? Because many times it's like, well, how come? Because if pharma communications are done right in culture, being culturally relevant, and in language when needed, right? They fill in a gap, an information gap that multicultural groups kind of like immediately understand it and they go to it and they feel that they're receiving value. And once they feel that they're receiving value through disease education and treatment education and connections with, let's say, partnership organizations where they can build community and support, at that point, they trust pharma brands more than their non-Hispanic or non-Asian white counterparts. So there's such an opportunity and a responsibility for pharma organizations, healthcare organizations to do the job right, to understand the culture, to use data-driven approaches like this ones, and to build culturally sensitive work out there to put it out there for both the patient and then the HCP on the cultural competence side to really fill in this gap and build the trust.
That's very interesting because I think, yes, to your point, we think, well, they don't trust the healthcare system. They are definitely not going to trust pharma. That's really interesting. So I don't know if the research got into this specifically, but so when you think about the patient journey, say someone is researching a health condition that they think that they have or they got diagnosed with, are they going to pharma websites? And I'm wondering from the lens of when they have conversations with their doctors, is there some brand loyalty that they're already like coming into the conversation with? Or is it more like later in the patient journey after a diagnosis, after a doctor has maybe recommended a certain treatment that they're then going? Like, how are they engaging with pharma? At what point in their journey would you say? I mean, I'm sure at various points, but I'm just curious if there was like a trend there.
Great question. And it's all from the get-go. So
Okay.
all the way from disease education, if you do have a disease education campaign that it's helping them understand their condition or their family member's condition, that's a great opportunity to be able to add value and start building a relationship. But then from there, treatment awareness. We see, and we started researching for this report, like all the different touch points. We see that anything when it comes to digital information, multicultural groups are over-indexing to find treatment information even before they go to their doctors. And if it's done smart in the right way, and you're coping the treatment information with resources to prepare them for a conversation with their doctors, like a doctor discussion guide, like bilingual, for example, nurse educators that can help answer questions and prepare them before they even go to their doctors, then at that point, you're empowering them and you're starting to build a relationship from the get-go. But then once they go into the doctor, they also over-index in point of care, using point of care resources as a source of information, and both digital and printed. So while they're waiting, if you do put out there information that is culturally relevant and that it's in language, then that is another touch point that is going to be key help patients. And then, of course, after they get a prescription, they're going to go back and do the research on safety and efficacy. And then farther down the line, in order to adhere, because multicultural groups are less likely to adhere to treatment because of the multiple factors that we have already mentioned. But if you offer support through your side, through resources, again, like APPs, like nurse educators, and so on, to the patients that are already in treatment, they're more likely to adhere. Right. So it's all throughout the journey. You can be there for them.
It's all throughout the journey. It's all the different players. It's an entire ecosystem that we need to understand because everyone is coming into it, like, and we always say this, it doesn't, like, we're talking about humans here. Yeah, sure. Like someone's a doctor, someone's a patient, someone's, on the insurance side, but they're all humans and they all have their biases and they all have a certain background that's resulting in a belief and a behavior. So what I love about this conversation is we're talking about one group. We're talking about the patients, and they're one part of this ecosystem. The HCP and the provider side is equally as important as part of this equation to make health outcomes be what we want them to be. So I love that this is part one, and part two is talking about that side, because oftentimes I think we focus on research that's on one side, and then there is research on the other, but then you're kind of trying to like, okay, well, if a doctor thinks this and a patient thinks this, then like, where do they meet and where are the gaps? And I love that this research was done hand in hand on both sides, because then you really can look at them side by side and say, okay, what do we take away from this, and where's the meeting point? Where's the gaps? So again, just like, to our listeners, get excited because we are going to be talking about the other side. And Ada, I love that we took that approach when you guys did this research.
Can I just jump in and say that another part of this that I really enjoy is that it's highlighting the fact that multicultural patients are putting in the work, and the work is inspired from like their mistrust, from the lack of health literacy they may have. And despite that They may not have the health literacy of white counterparts. They are still intelligent and they are not lazy. Like they are doing this work. They are raising their hand. They are seeking out information in order to close that gap. And so, Ada,
Yeah.
I think the way that you said it before was like, there's an opportunity for us, especially in advertising, right? There's an opportunity for us to meet that gap, to meet that need. There's a demand here to take it to a strict business sense. People want this information.
Exactly.
Yeah.
It's a business opportunity and it's also a moral obligation. And the way we
Right.
build campaigns is that we build them with brand goals and health equity goals hand in hand with separate KPIs. So we ensure when we partner with a brand that we do it right, that we're driving business, but we're also driving impact and we're helping close inequities, close the gaps. If we don't get a buy-in from a brand to really have this holistic approach, then we really don't go in, because that is the only way to do it right, looking at both sides of the spectrum.
Totally. I love what you said, Gabe. And I think there's so much in this paper that we need to be highlighting and considering when we do our work. But like, yes, if I could just say one thing, and it's similar to what Gabe was saying, it's like mistrust, misunderstanding, access issues, all of these barriers that we have been aware of does not result in a disengaged patient. This research has found the opposite is in fact true. And our job is to say, like, we have someone who is feeling deep feelings of mistrust, still seeking information. How do we need to present the information knowing that this person is in this place? And, so there's obviously a psychology component to it that's very important. But yeah, to me, at least, that's a huge takeaway. I think that there's still this understanding of like they're disengaged, they are avoidant, they have an avoidant health style. So yes, I just want to like also highlight that because that's awesome and so important to call out. So, all right, well, I think we can like easily go another hour, but we won't do that to anyone. So let's close this out. Like I said, there is going to be a part 2. Ada, thank you so much. Is there anything that you didn't get to touch on that you want to?
Yes, very, very fast. I mean, first of all, thank you both for the work that you do, for, being smart, empathetic individuals that are putting this great information out there into the world, because we need 1,000 or millions of Sonikas and Gabes out there helping raise awareness of such important issues. I will just say that if you're out there and you're a healthcare marketer or a healthcare provider or within the healthcare system and thinking like, well, where do we start, right? And just very high level, I will say data-driven approaches, not because we're talking about multicultural patients. It means that you can just go by stereotypes on or by what someone thinks is like data-driven approaches is what really helps. Then cultural competence training. Make sure that there are cultural competence trainings as part of your offerings within your organization. Then dedicated resources when it comes to cross-cultural marketing. It can be an afterthought. You have to have dedicated resources as part of your trainings and as part of your campaigns. And those campaigns really need to be led, and you need to partner with cross-cultural experts. And cross-cultural expertise goes across all the different disciplines when you're building a communications plan, a campaign, or a community plan. And then finally, ensure that you also have advocacy components in order to address access barriers, because the information and the education is key. Access barriers also are a huge part of the equation to move the needle on health equity.
Amazing. Thank you so much. We are going to link the white paper, as Gabe mentioned. We are going to link Ada's information, if that's okay. If you have any questions, feel free to reach out to her team. And yeah, you'll be getting another conversation very soon from the three of us. So we're very excited.
Thank you, guys. Super excited.